Cool, great. Okay, well, good afternoon, everyone. As Jeremy says, this is quite a common reason to be consulted, and fever and rash syndromes can be caused by very many different things, and it is one of the consults that I dread because I hate being asked to look at a rash. So I thought I would review it, and hopefully it would help me approach rashes better. So a lot of the causes can include infection, local or systemic. It can also be toxin-mediated disorders, including those associated with bacterial superantigen production. It can also be inflammatory conditions, including vasculicities and rheumatological diseases and hypersensitivity disorders. As I said, I'm going to try and get a good systematic approach, and that should help us to be able to reach the correct diagnosis. I'm not going to talk about all fever and rash syndromes. I'm only going to talk about systemic rashes. I'm not going to talk about rashes in neonates or in immunocompromised children. Okay, so it's important that we're all speaking the same language when we're describing rashes. Also make you sound more professional, and it can suggest that you actually know what you're talking about. So if we look at the dermatological definitions for rashes, it looks at whether they are raised or flat, and then also looks at the size of the lesion. So if you feel the skin and you can feel a bump, that's an elevated solid lesion. If it's less than 1 centimeter, it's a papule, and larger than that, it's called a nodule or a plaque. If it is flat and there's a change in the color or the texture, and it's less than 1 centimeter, it's a macule. Larger than that, it's a patch. And then fluid-filled lesions are vesicles or bullae, pus-filled lesions are pustules or abscesses. And when there's extravasation of blood into the skin, if it's a pinhead, it's called petechia or purpura, and then if it's larger, ecchymoses or hematoma. And when there's dermal edema or edema deep in the skin, we call that a wheal or angioedema. Also to know that exanthem is a rash on the outside of the body, and enanthem is a rash on the inside of the body, on your mucosal surfaces. So just here, this is a picture of a maculopapular rash, and the macule is the non-palpable flat lesion, the papule is the palpable. And when they can become confluent, and then we call it maculopapular. And when it's more confluent, it's also sometimes called mobiliform, because that's what the measles rash looks like. And then in scarlet fever, you can get a rash with multiple small papules that feels like sandpaper, and that is described as scarlatiniform. Maculopapular rashes are usually seen in viral illnesses, but also in drug eruptions and in immune complex mediated disorders. A purpuric lesion is a non-blanching macule or papule. And this is important, whenever you see a macule or a papule, you need to ask yourself whether it can blanch or not, because this could be a sign of meningococcal infection. And this is an illustration of the glass test. So if a child is febrile and has a rash that does not blanch when pressed under glass, then you need to assume that they've got meningococcal septicemia, and until proven otherwise. If you are working in a peripheral hospital or want to transfer the child, it's vitally important that you give an intravenous third-generation cephalosporin before transferring to hospital. Obviously, we'd all prefer you to do a blood culture before then, but if you're not able to do that, then it's better just to give the Keftrax. Okay, so when I look at fever and rash syndromes, I've tried to break them up into infectious and non-infectious causes. The non-infectious causes, actually, a lot of them are initiated by infection, so it's not as simple as that, but they are allergic or immune mediated, or inflammatory, rheumatological, or oncological. So allergic or immune mediator could be urticaria, erythema multiforme, or Stevens-Johnson syndrome, and toxic epidermal necrolysis. Urticarial rashes are intensely pruritic. Erythema multiforme has the classical target lesions, They're often cutaneous and mucosal. If there's mucosal involvement, it's called erythema multiforme major. And if there's no mucosal involvement, then it's minor. Stevens-Johnson and TNN often occur on the face and the trunk, and the rash develops into loss of the epidermis. So here's some pictures showing us an urticarial rash. And the hallmark of this is it's intensely pruritic. It's annular, edematous, mildly erythematous plaques, and they lack that central dusky or target lesion that you get with erythema multiforme. The individual lesions are also usually transient. They last less than 24 hours. And common causes of new onset urticaria actually include infections, and it's an immune-mediated response to the infection that results in the rash. It can also be an allergic reaction, a type 1 IgE reaction to medications or foods or insect stings and bites. But infections are actually associated with over 80% of cases of acute urticaria. Children also who have a viral bacterial infection are often given antibiotics, and then they get urticaria. And the urticaria is actually usually related more to the viral infection than to the antibiotic. And it's really only the minority of the children who develop an urticarial rash who have a drug reaction. So if we look at the causes of urticarial rashes, can occur in the prodrome of in the pre-icteric phase of both hepatitis A and B, and to a lesser extent hepatitis C. It can even be the initial manifestation of HIV infection, and can also be associated with enteroviruses and EBV. Acute urticaria, which doesn't respond to antihistamines, can occur with mycoplasma pneumonia and will respond to treatment with azithromycin. It's also associated with group A strep, Shigella, meningococcus, and Yersinia. And a whole host of parasites can also cause an urticarial reaction, and they often have associated eosinophilia. This is a typical target lesion you get in erythema multiforme, and there are three components. The one is the dusky central area, which can often be a little blister, and the dark red inflammatory zone with the pale ring of edema, and then the erythematous halo. And these pictures show the multiple typical target lesions that you usually get in acral distributions on your legs and arms, and can even involve the palms. And then mucosal erosion and crusts on the lips can occur with erythema multiforme major. This is usually acute and self-resolving, but it can be recurrent as well. And the causes of erythema multiforme, there are many causes. Herpes simplex virus is the most common cause, and less than 10% of cases of erythema multiforme are associated with medications. Pathogenesis of herpes simplex induced EM is thought to involve a cell-mediated immune process that's directed against viral antigens that are actually in the skin, and you might have a genetic susceptibility to it. But if you look at the causes, it's quite a lot of viruses. Mycoplasma is quite a common cause as well. Salmonella, TB, histoplasmosis. And we saw a child who presented with erythema multiforme who turned out to have MIS-C, or the multi-system inflammatory syndrome with COVID. And then this is Stevens-Johnson syndrome with 10, and vesicles and bullae are characteristic cutaneous findings. Usually start on the face and the trunk, and then you start getting skin loss. And Stevens-Johnson is not usually associated with infections. It's most commonly due to drug reaction. And the difference between Stevens-Johnson and toxic epidermal necrolysis is distinguished chiefly by the percentage of body surface area affected by blisters and erosion. Stevens-Johnson is less severe, and it's where skin detachment is less than 10% of the body, whereas 10 is when there's more than 30% of the body surface area that's involved. And you can see that the oral manifestations can also be quite similar to erythema multiforme major, so it can be difficult to differentiate them. All right, and in children, the medications most commonly associated are sulfonamides, but also anti-epileptics and some antimicrobials. And the most common infections are mycoplasma pneumonia. And it's thought that patients with HIV infection have an increase of drug reactions and almost 100-fold higher risk of Stevens-Johnson syndrome than the general population. And the morbilliform drug eruptions are often indistinguishable from viral exanthems, and they present up to 7 to 14 days after starting a drug. And as with most viral rashes, the rash starts on the trunk and spreads to the extremities. And examples of causative agents are aminopenicillins, cephalosporins, antiepileptics, and sulfonamides. And the drug eruption usually resolves spontaneously after stopping the drug, but sometimes they're the first sign of a potentially life-threatening syndrome called drug rash with eosinophilia and systemic symptoms, or DRESS. And these photos on the right, you get a fine pink macules and papules that are becoming confluent on the posterior upper arm, and you can see that the dependent area, the rash is more confluent there. And the picture on the left is showing a more edematous or urticarial pink papules. And unlike urticaria, these lesions don't go away within 24 hours, they stay. So DRESS, or drug reaction with eosinophilic and systemic symptoms. This is a severe adverse drug reaction, and you get extensive skin rash. The skin rash is usually maculopapular, and it's associated with visceral organ involvement, especially the liver. You can get increased AST and ALT, and you also get lymphadenopathy. On the FBC, you can see eosinophilia and atypical lymphocytosis. The presentation is heterogeneous, and the disease course is typically quite prolonged. And despite stopping the drug, you continue to get flares of disease that can continue. And the rash will only start usually within 2 to 8 weeks after starting the drug. And interestingly, it's associated with reactivation of latent human herpes virus infections, especially HHV6, CMV, and EBV. And the drugs implicated in DRESS, again, there's a whole long list. I think allopurinol is the prototype almost, but you also get anti-epileptics and sulfonamides, nevirapine, and anti-TB drugs, but also antibiotics have been associated with it before. So the next category we're going to look at is inflammatory or rheumatological. So systemic juvenile idiopathic arthritis, SLE, dermatomyositis, Kawasaki's disease, Hemlock-Schönlein-Purpura, MIS-C, and hemophagocytic lymphohistiocytosis. So the systemic form of juvenile idiopathic arthritis can present with a salmon pink rash that is evanescent. That means it comes and goes very quickly. You might have small pink macules on the arm, and then it disappears within an hour and reappears on the trunk. And the rash may precede arthritis, so it's important that you have it as a differential. The arthritis can be oligo or polyarticular, but it's important to make the diagnosis because untreated JIA can lead to erosion of joints and blindness from uveitis. I'm not going to talk much about SLE or dermatomyositis because I think most of you are aware of how they present, the SLE with the butterfly rash. And I'm going to now go and talk about Kawasaki disease. This is also called mucocutaneous lymph node syndrome, and it is one of the most common vasculitides of childhood, and it occurs only rarely in adults. It's typically a self-limited condition with fever and manifestations of acute inflammation, which can last for an average of 12 days without therapy. So it's characterized by the systemic inflammation with high fever, And it needs to be a differential in your differential for any child who presents with fever for more than 5 days. And you also get evidence of mucocutaneous involvement with bilateral non-exudative conjunctivitis, erythema of the lips and oral mucosa. You can get a maculopapular rash. You can get changes on the extremities with edema of the hands and feet. And then later you can get desquamation, and you can get cervical lymphadenopathy as well. And you don't get all these findings at the same time. They sort of come and go. And that's why you need to keep this diagnosis in mind and try and put it all together. So the diagnostic criteria, you need fever for 5 days, and then at least 4 are the following: the conjunctivitis, erythema and cracking of the lips and your cervical lymphadenopathy, which is usually unilateral, the maculopapular or diffuse erythroderma or erythema multiforme rash, and then erythema and edema of the hands and feet in the acute phase, and desquamation around the nails in the subacute phase. This is just a graphic showing you that different signs and symptoms appear at different stages. Fever occurs quite early on, as does the conjunctivitis and the involvement of the oral mucosa and the cervical lymphadenopathy. The rash usually only occurs at the end of the first week, and then you also get the edema and erythema of the palms and soles. And then only at the end of the second week are you going to see the peeling of the fingers and toes. The worry with Kawasaki disease is that you can get coronary artery aneurysms, and that can result in sudden death. You can also get associated myocarditis or pericarditis. And once you've made the diagnosis, you want to give the treatment before the end of the second or third week, before the coronary artery aneurysms develop. And IVIG or immune globulin has been shown to prevent the development of coronary artery aneurysms. And then MIS-C, the new multi-system inflammatory syndrome associated with COVID, has been, myriad of rashes have been described with it. And this is an inflammatory reaction that occurs, usually about a month after the child had COVID infection, after the COVID infection was asymptomatic. And then they present with inflammatory signs quite similar to Kawasaki disease. They're usually much older though. They can have the strawberry tongue with hyperemia, conjunctivitis, the facial erythema, can even have periorbital edema. And then there's a picture there showing palmar erythema. Children have been described also with urticarial rashes. The middle picture is showing a scarlatiniform rash, a mobiliform rash, and the bottom one, a lacy reticulated rash. So there are quite a diverse spectrum of rashes you can get with MIS-C. IgA vasculitis used to be known as Henoch-Schönlein purpura, and this is the most common form of systemic vasculitis in children. And you get IgA immune complexes deposited in the wall of vessels. 90% of cases occur in pediatric age group, but you can see this in adults. And in contrast to many other forms of systemic vasculitis, IgA vasculitis is actually usually self-limited in the majority of cases. And they're usually a tetrad of clinical manifestations. You get palpable purpura, it's usually on a dependent surface, so mostly the buttocks and the legs. And there is no associated thrombocytopenia or coagulopathy. They also get arthritis and arthralgia and can have edema of hands and feet. They often have abdominal pain, and they can have interception and melena, and then renal disease, which can be glomerulonephritis, and get hematuria and proteinuria. And about half of the cases had a preceding upper respiratory tract infection, especially streptococcus, but other infectious agents, vaccinations, and insect bites have all been thought to trigger IgA vasculitis. It affects the vessels in the skin, joints, GIT, and kidneys. And the rash is initially urticarial, and then it frequently evolves into maculopapular eruption. And after this eruption, you can get petechia, and then the purpuric plaques can start to develop. and they are typically raised and you can feel them quite easily. Hemophagocytic lymphohistiocytosis can present as a pyrexia of unknown origin. It is an aggressive and life-threatening syndrome of excessive immune activation, and it can be precipitated by a variety of infections, malignancies, and inherited variants of genes that are important for well-regulated immunity. It most frequently affects infants from birth to 18 months of age, but disease is also observed in children and adults of all ages. The skin manifestations are quite varied. They can include rashes, erythroderma, edema, petechia, and purpura. And in adults, a skin rash was reported in up to a quarter of cases. And the first picture shows a neonate with generalized purpuric lesions, and the other neonate has this reticulated lacy rash. And the worry with this is it can rapidly evolve into multi-organ failure and can be fatal. Just to remind us of the diagnostic criteria, it's 5 of the following. We don't always test for some of these things, but you want the fever, often splenomegaly, peripheral blood cytopenia with at least 2 of anemia, thrombocytopenia, and neutropenia. And then they classically have high triglycerides and a very, very high ferritin. Usually it's more than 3,000. And if you do a bone marrow, you can see evidence of hemophagocytosis. There's also hemophagocytosis in the spleen and lymph nodes or liver. And if you have access to fancier immune testing, you note there's a low or absent NK cell activity, elevated soluble CD25, and elevated CXCL9. I'm not going to go into oncological manifestations. In fact, they are quite rare. This is a picture of a child with leukemia cutis, and it's not often seen. And there are numerous erythematous papulas coalescing into thin plaques on the face, trunk, and extremities of this girl. Other malignant skin manifestations can be seen with histiocytosis, can present with erythema nodosum, or with mastocytosis. I'm going to go look at the infectious causes. It can be, as we classically describe, viral, bacterial, helminths, protozoa, or fungi. But in the interest of time, I'm not going to be going through all of them. And I'm going to concentrate on the viral and bacterial causes. The common viral exanthems are measles, which is also known as rubella, roseola, fifth disease, otherwise known as erythema infectiosum, chickenpox, enterovirus, EBV, and Giannotti crusty. So measles is a rash that usually occurs in unvaccinated children. Classically, it used to be in winter or spring. It's an airborne virus, and it's very, very infectious. It can hang suspended in the air for up to 2 to 4 hours after someone has left the room, and therefore it can spread even when that person is no longer there. The incubation period is usually about 12 days, and you're contagious from 5 days before the rash to 4 days afterwards. The prodrome is you have a high fever before the rash, which occurs usually about 4 days afterwards, and you get the 3 C's, your conjunctivitis, coryza, and cough, and you can have Koplik spots, which are white spots on the buccal mucosa, and it's seen against a bright red background. And then the rash is maculopapular. It begins on the face and spreads to the trunk, and it quickly becomes confluent. After about 3 to 6 days, it becomes a brown color and can desquamate. And the child is usually very ill looking, and they can have photophobia. And complications of febrile seizures, otitis, pneumonia, encephalitis, LTB, thrombocytopenia. And the dreaded complication we're all worried about is subacute sclerosing panencephalitis, or SSPE. This can occur 2 to 10 years after the child had measles, and it presents with change in personality. They can get myoclonic jerks, and they get regression of milestones, and it's universally fatal. It occurs only in 1 in 100,000, but there is no treatment for it, and it's diagnosed by getting measles IgM in the CSF. The other thing about measles is it can wipe out all your memory cells, and it makes you vulnerable to other infections for up to 1 to 2 years after you've had it. Here are some more pictures. The first one is the Koplik spots. They're the blue-white spots on the erythematous base. And then you see the characteristic maculopapular rash that is confluent. And prevention is obviously by giving the measles vaccine. At the moment in South Africa, in the state sector, we're giving it at 6 and 12 months. And it can also be part of MMRV, measles, mumps, rubella, varicella, which you would give at from 12 months of age, and then a booster at 4 to 5 years. If someone who's not immune is exposed to measles, you can give them the measles vaccine if it's within 72 hours, and you can give the immune globulin if it's within 6 days of exposure. And WHO recommends that all children with measles should get high dose vitamin A, and don't forget that it's a notifiable disease. Any child who's got cough, coryza, and conjunctivitis with fever and develop the rash, they need to be notified for measles. Rubella, this is otherwise known as German measles, and this is spread by respiratory droplets. Incubation period is 14 to 21 days. You have a prodrome of malaise and fever. The clinical manifestations are generally mild, and many cases are actually subclinical or asymptomatic. And illness is usually much milder in children than in adults, and they can just have a low-grade fever. The lymphadenopathy is characteristically posterior auricular and suboccipital, and the exanthem consists of pinpoint pink macular papules, and the rash first starts on the face, similar to measles, and then spreads to the trunk and can become generalized within 24 hours. The rash is usually evident for about 3 days, and can last for only 1 to 2 days, or occasionally as long as 8 days. And although the distribution of the rash is similar to that of measles, the spread is much more rapid, and the rash does not darken or coalesce. They can get a mild conjunctivitis, and they can get an enanthem. They can get variable erythematous macules on the soft palate. Complications are arthritis more in adults, but they can occur in children, and thrombocytopenia and encephalopathy. One of the dreaded complications is congenital rubella syndrome in a pregnant woman, and prevention is with rubella vaccine. It's a live attenuated vaccine, so you can't give it during pregnancy, and it's not part of the EPI at the moment. Roseola is exanthem subitum. This is from HHV6 and also HHV7. Some people call it the baby measles, and there is no particular time of year that it's seen. The prodrome, these children can be irritable with very high fever for up to 3 to 7 days. They can have lymphadenopathies, cervical and occipital. And then the classic thing about this is that the rash, a maculopapular rash, appears, and suddenly the fever disappears and the child is much better. So you can also get variable macules on the soft palate. So often children would have been given antibiotics for the fever, and then they develop a rash, and people think they've got an allergy, whereas they didn't need the antibiotic in the first place. Complications of this, it's a classic cause of febrile seizures, and it can cause encephalopathy and dissemination in immunocompromised patients. Parvovirus, B19, or erythema infectiosum, this is also known as slap cheek disease, and this occurs in prepubertal school children, occurs in winter and spring, and is transmitted by respiratory droplets or blood transfusion or via the placenta. Incubation period is 5 to 15 days. Often there is no prodrome, or they can have headache and malaise and myalgia. And there's not always a temperature with parvovirus B19 infection. A day after the slapped cheek rash occurs, they can get a symmetric macular lace-like and often pruritic rash that occurs on the trunk and moves peripherally to involve the arms, buttocks, and thighs. And the rash can fluctuate in intensity, and it recurs if it gets hot or if it gets cold, or if you're exposed to sunlight, and it can actually recur for weeks to months after the infection. You can also get arthralgia and arthritis with parvovirus B19 disease. And the picture at the top right-hand corner is a picture of stocking glove purpura. This is also associated with parvovirus B19 infection. And this is a picture in an 18-year-old girl who woke up one morning with asymmetric symmetric purpura of the hands and feet. The complications, because there's a tropism for the pre-erythrocytic red blood cells in the bone marrow, can be associated with aplastic anemia, especially in children with a chronic hemolytic anemia, such as sickle cell disease. And it has also been associated with anemia, aplastic anemia in children with HIV infection. Often the children are asymptomatic, they don't develop a rash, and then they present with anemia, with an aplastic crisis. All right, I'm going to talk about chickenpox or varicella. And this usually occurs via airborne droplet, and the incubation period is 12 to 21 days. Complications are staph or strep skin infection, arthritis. You can get a post-infectious cerebellar ataxia, encephalitis, and thrombocytopenia. And you must never give a child with chickenpox aspirin, because they can get Ray's syndrome, which is a severe multi-organ failure syndrome, especially with an encephalopathy. And you can also get dissemination in immunocompromised patients. This rash shows the typical dewdrop on a rose petal appearance. And you also note the varying stages of development. So in a chickenpox rash, you should see macules, papules, and vesicles all at the same time. And the picture on the right shows a neonate with chickenpox. In immunocompromised patients who are exposed to chickenpox, you can give them varicella immune globulin, and that's recommended for susceptible pregnant women, preterm neonates, and infants at birth whose mother developed varicella 5 days before or 2 days after birth. And the question of whether you should treat all children with acyclovir or only immunocompromised is controversial, and children are contagious for only until all the lesions have scabbed over. And this is a picture of an immunocompromised child who developed hemorrhagic chickenpox. I'm going to talk about enterovirus, and one of the classic presentations of enteroviral disease is hand, foot, and mouth disease and herp angina, and that's usually caused by Coxsackie A16 and enterovirus 71. Typically occurs in summer and early autumn, and most cases occur in children younger than 5 to 7 years, but it can occur in adults. And enteroviruses are usually transmitted by the fecal-oral route, but they can also be transmitted by oral and respiratory secretions, and in the case of hand, foot, and mouth disease, by the fluid of the vesicles. The incubation period is usually 3 to 5 days. And hand, foot, and mouth disease presents with mouth or throat pain, and the child will often refuse to eat. If present, the fever is generally low grade, and the oral lesions may actually occur in isolation, and they can begin as macules, progress to vesicles, and then rupture to form superficial ulcers. The oral lesions are very, very painful, and that's why they can interfere with oral intake. The skin lesions, on the other hand, which can also occur without the mouth lesions, are usually non-pruritic and non-tender, and they may be macular-papular, or vesicular, and they can involve the hands, feet, and the buttocks, particularly in infants and young children, and even the legs and arms. So non-polio enteroviruses, the Coxsackie, echoviruses, and others are responsible for significant and frequent illnesses in infant and children, and they can result in multiple clinical manifestations. One of the most common manifestations is just a non-specific febrile illness, and especially in young infants can lead to evaluation for bacterial sepsis, and it can be quite significant and can cause severe illness in newborn babies. And then the pictures are showing the macular-papular rash, which can be papular-vesicular or petechial, and it can also occur on the hands and soles and the buttocks. The rash may appear at the same time as the fever or after the fever disappears, and in up to 50% of enteroviral illnesses, there is no rash at all. And the children can be contagious for up to 2 weeks after they've had it. And the incubation period is about 4 to 6 days. Epstein-Barr virus doesn't usually cause a generalized exanthem, and it's usually transmitted by close contact with saliva or blood transfusion. It's known as kissing disease because adolescents classically get it after kissing from saliva. The incubation period can be as long as 49 days. It's usually about 28 to 49 days. And infectious mononucleosis is the most common presentation of EBV virus. It typically manifests as fever, pharyngitis with petechia, exudative pharyngitis, lymphadenopathy, hepatosplenomegaly, and atypical lymphocytosis. And the spectrum of disease is very wide. A lot of children or adolescents are completely asymptomatic, and especially young infants and children are asymptomatic, and infection goes unrecognized. The rash that you see on the left is more common after treatment with amoxil and can be diagnostic. You give ampicillin and they develop this more morbilliform rash. Gianotti-Crusty syndrome is also known as papular acrodermatitis, and it's a self-limited skin disorder that most often occurs in young children. Viral infections, and especially hepatitis B, are common precipitating factors for Gianotti-Crusty syndrome. And it typically manifests as a symmetric papular eruption. Classic sites of involvement include the cheeks, buttocks, and extensive surfaces of the forearms and legs. And it can be intensely pruritic, or it can be asymptomatic. And the papules typically resolve usually within 4 to 10 days, but usually within 2 months, but it can persist for longer. Here's another picture of the characteristic rash. So in South Africa, where all children are immunized against hepatitis B, we don't see it as commonly, and now EBV or Epstein-Barr virus is the commonest cause of this, and it can also occur with Coxsackie viral infections. Okay, so now I'm going to look at common bacterial exanthems. The ones I'm going to look at are scarlet fever, staphylococcal scalded skin syndrome, toxic shock syndrome, meningococcemia, and tick-bite fever. So scarlet fever, which is also known as scarlatina, is a diffuse erythematous eruption. It generally occurs in association with a pharyngitis. And the development of scarlet fever rash requires prior exposure to strep pyogenes, and it occurs as a result of a delayed type skin reactivity to pyrogenic exotoxin, also known as erythrogenic toxin, and that's produced by the strep pyogenes organism. Classically occurs in school-aged children via direct contact with droplets. They present with sore throat, a headache, abdominal pain, cervical lymphadenopathy, and fever. And about 2 days after the fever, they can get a diffuse erythematous macular-papular rash with a classic sandpaper texture. And they can also develop a red strawberry tongue. There's tongue initially coating, but it desquamates to result in a red tongue with prominent papillae. And then after the illness gets better, they often get desquamation of their palms and soles. They also classically have circumoral pallus. So they have this red strawberry tongue, and then around their lips, it's quite pale. Here's a nice view of the sandpaper type rash, where you get numerous small papular elevations. And the other thing about the rash is it has it usually starts in the groin and the armpits and rapidly expands to cover the trunk, and it ultimately desquamates. And the rash is most marked in the skin folds. So then the inguinal, axillary, and cubital areas around pressure points. And you often get these classic linear petechial reactions in the skin folds. And this is called Pasteur's lines. And you need to treat treat scarlet fever with penicillin to also prevent rheumatic fever. And you can get a similar syndrome in adolescents with Arcanobacterium hemolyticum. And Staph aureus can also produce a scarlatiniform rash. Okay, so we're going to talk about staphylococcal scalded skin syndrome. This is you can get a sudden onset of tender erythroderma, which progresses to diffuse flaccid bullae, and you get significant peeling. You get a positive Nikolsky sign, where when you rub on the skin or cause friction, you get peeling of the skin. And staphylococcal scalded skin syndrome is a toxin-mediated disease, much like scarlet fever, and it's caused by exfoliative toxins A and B. And the type of manifestations you get from the infection depends on your age. Neonates can get generalized exfoliation, and you can see the top right-hand picture. That child looks like he was scalded with hot burning water. Older children will get more localized bullous lesions. They can get bullous impetigo, or a combination of bullous impetigo and thick white, brown, flaky desquamation of the entire skin. And the hallmark is the toxin-mediated cleavage of the stratum granulosum, which is the Nikolsky sign. Bacteremia is rare, but they could get a secondary superinfection. And this is pictures in an older child with a bullous impetigo. So toxic shock syndrome is a severe, potentially lethal condition that requires prompt recognition and aggressive treatment. It can be caused by Staph aureus or Strep pyogenes, and streptococcal disease carries a worse prognosis. Staphylococcal toxic shock syndrome may be either menstrual or non-menstrual in origin, and the menstrual disease is associated with a better prognosis and is due to use of tampons with superabsorbent properties. And this young infant shows hyperemia of the lips, the red lips and the swollen eyelids with capillary leak. And the toxic shock syndrome is a super antigen that polyclonally activates up to 10% of all your T cells and causes rapid release of multiple cytotoxins. I'm not going to go through all the definition, all the clinical findings, but there are different definitions for staphylococcal aureus toxic shock syndrome and for streptococcal toxic shock syndrome. And the rash you can get in staphylococcal toxic shock syndrome can be an erythematous macular-papular eruption on the abdomen, and it can look quite similar to sunburn or a chikungunya type rash. And then you also get desquamation of the palms and soles 1 to 2 weeks after the start of the illness. So streptococcal toxic shock syndrome has its own definition. And I think the hallmark of the toxic shock syndromes is the hypertension and the involvement of multi-organs in the illness. Meningococcemia is another illness you want to pick up urgently, you get multiple purpura, and it follows close prolonged contact. The ages at risk are infants and then adolescents when they, go to varsity and live in dormitories or go to military barracks. And they can present with shock, meningitis, and Haemophilus influenzae, and group A strep can also present quite similarly to meningococcal infection. So in South Africa, the classical clinical triad of fever, escar, and rash occurs in up to 50 to 75% of tick bite fever. The escar may resemble an infected insect bite or skin trauma and early anthrax lesion, and the rash may suggest rubella, measles, secondary syphilis, or disseminated gonococcal infections. But it's important to think of this diagnosis so that you can treat it with doxycycline. All right, so you've seen a lot of pictures of rashes. I'm sure they're all tending to blur into each other. So it's important to have an approach. How can we approach this? And I think one of the most important things is to get a thorough history. You can look at the age of the child. So school-age children are more likely to get scarlet fever, rheumatic fever, for example. Neonates and infants are staphylococcal scalded skin syndrome and Kawasaki disease. Ethnicity, for example, Kawasaki disease is more common in children from Japanese or Korean ethnicity. And it occurs, when is it occurring? Summer and autumn is more enterovirus. Winter or early spring is Kawasaki. And the medical and family history should also be used to assess the overall health of the patient, as well as that of the family. You need to decide if there's an underlying primary or acquired immunodeficiency. And you want to know about travel history, something like chikungunya or dengue fever. And you want to know about ticks. And ticks can be hidden in hairlines or between the toes. Immunization history is very important. Measles immunization is very effective and should prevent measles infection. And you want to know about, prior infections as well. And then you want to look at the rash itself and look at the features of the rash. There is a differential for maculopapular rashes or petechial or diffuse erythroderma. Is there a positive Nikolsky sign? Where did the rash start? When did the rash appear in relation to the fever? And all these things can be clues. And then how does the rash progress? And then is the rash painful or itchy? And then you want to look at the associated enanthem. Are there lesions in the mucosa? The buccal mucosa, the palate, the pharynx, and in the genitalia. So you were to remember one thing from this talk: any child who has a rash, you need to assess for signs of toxicity. So you want to look for lethargy, irritability, altered mental status, decreased activity, poor perfusion, pallor or cyanosis. And, often a child who comes in can look really toxic and ill if they've got a fever. And even though fever is a protective mechanism that has evolved over millennia to help kill off organisms, this is the one situation where you'd want to give paracetamol so that you can assess the child without a fever. And if the child is happy and, generally their normal self when they don't have a temperature, then they're less likely to be toxic. But you want to look for signs of sepsis, and a tachycardia or tachypnea can suggest sepsis. So always count the heart rate and the pulse rate. And tachycardia can also be seen, obviously, in endocarditis or myocarditis. And a change in mental status can suggest either sepsis or decreased organ perfusion or primary meningoencephalitis. If you've got hypotension, that could be a sign of septic shock or toxic shock syndrome or dengue hemorrhagic shock syndrome. And hypertension can be associated with vasculitic disorders such as polyarteritis and SLE. You can look at ocular manifestations. So is there conjunctivitis that can be associated with measles, adenovirus, leptospirosis, Kawasaki disease, Stevens-Johnson, or reactive. You might want to look at cardiac manifestations for Kawasaki disease, MIS-C, or juvenile arthritis, and lower respiratory tract findings with a lower respiratory tract infection can be suggestive of measles, RSV, adenovirus, mycoplasma, and arthritis can be associated with gonorrhea. You could get a reactive arthritis, and in children it can be associated with conjunctivitis and urethritis. And the enteric pathogens we think of are Salmonella and Shigella, or in our adolescents you can think of gonorrhea or chlamydia. If you want to look at the type of rash, you can also say maculopapular. There are viruses, bacteria, rickettsia, or other can all present with the maculopapular rash. And the classic childhood exanthems are maculopapular. And the things that are going to help you are to look at the clinical characteristics of the rash. So for example, in measles, you're going to have fever for a few days, and you're going to have coclic spots, you're going to have conjunctivitis, coryza, and cough. And then, a few days later, you're going to get the rash, which is going to start off behind the ears or on the face and spread to the trunk. And on the third day of the rash is going to start becoming confluent, especially on the trunk and face. Whereas with rubella, on the first day of the rash, it starts on the face as well, and it goes to the trunk and the arms, and it's more discreet. But by the third day, it's becoming more peripheral, or even it's disappeared. Scarlet fever, the rash develops, within maybe 2 days of the fever. You get the flushed cheeks, circumoral pallor, strawberry tongue, and the Pasteur sign, and it also blanches, and there's increased density in the groin. Just looking at measles, German measles, scarlet fever, and roseola, you can also look at the pattern of the rash and the fever to decide. And been through the measles and rubella, you can see the temperature is not that high, and it starts with, if you feel the occipital lymph nodes, that can often be a clue to German measles, and they far less commonly get conjunctivitis or coryza. Scarlet fever, the rash starts quite close to the fever, and they can have a sore throat as well. And roseola is very, very classic in that you get the high fever, and as soon as the fever disappears, the rash comes out and the irritability goes away, and they're much, much better. What about a child who presents with diffuse erythroderma? This is often associated with toxin-mediated disorders and characterized by superantigen production. And that's associated with staphylococcal skin syndrome, scarlet fever, toxic shock syndrome, maybe even Kawasaki's disease. But just to bear in mind that disseminated candida can also present as a diffuse erythroderma. The urticarial rash I've been through before. Vesicular bullous rashes, so sharply demarcated raised lesions containing fluid. The classic ones are your herpes, varicella zoster, and Coxsackie virus, but also to think of your bacteria, your staph with a bullous impetigo, group A strep, and gonococcal infection. And then your non-infectious toxic epidermal necrolysis or Stevens-Johnson syndrome. What about petechial purpuric? We always think of meningococcal, but there are other causes of it. And depending on the age of the child or how they present, it could be congenital rubella, CMV, enterovirus, HIV. A lot of bacteria can also present with petechia and purpura, and they can progress to purpura fulminans. A lot of rickettsia can also present with petechiae and purpura, and then obviously vasculitides with IgA vasculitis being the one we most commonly see. This is a picture of a blueberry muffin rash where you get what looks like purpuric lesions in the skin of a newborn baby, and that's extra medullary hematopoiesis. So any cause of a low hemoglobin in a baby will present like that, and this could be congenital rubella. Erythema nodosum are the erythematous and painful nodules, usually over the lower limbs. And this can be associated with viral infections, including Hep B and C, with bacterial infections, and most commonly group A beta hemolytic strep, fungal infections such as Candida, Cryptococcus, and then the one we all think of is TB, tuberculosis. But there are, can also be a presentation of lymphoma or Behçet syndrome. And then you get very distinctive rashes that are almost diagnostic. So ecthyma gangrenosum is that deep black rash with Pseudomonas or Vibrio vulnificus. Erythema migrans, or the classic bull lesion, bullseye lesion with Lyme disease, and necrotic eschar with mucormycosis, especially on the palate. Erysipelas is that extremely red rash with a sharply demarcated border with group A strep. The Koplik spots for measles, erythema marginatum for acute rheumatic fever. Erythema multiforme should usually make you think of herpes simplex or mycoplasma, and then rose spots in salmonella. So in dark skins, we don't often see erythema marginatum or rose spots. And this is a picture of erythema marginatum. You get these polycyclic red borders of erythema marginatum, and that's in a febrile child with rheumatic fever. So I've got a few cases that I've seen recently that we can go through, but I see it's almost 4. I don't know if we should rather just stop there and we can go to questions. Don't know what you'd like.
Jill, you're welcome to go ahead if we can do them quickly. I think that'll be good because it's a nice way to end.
Okay, cool. All right, so this was a 10-year-old girl who's HIV negative. She was known with a small VSD, and she developed endocarditis. And after 8 days in the ward, she developed this intensely pruritic rash over her trunk and limbs. And you can see as it evolves, it gets worse. Her face gets these almost raised lesions, and she even had a bit of a conjunctivitis. And she had this morbilliform reaction on her back and her arms. So I was wondering what you thought the most likely diagnosis was. We can just go over this if you think it's going to take too long. Should I just give you the answer?
We can launch a poll.
Okay, launch a poll. Okay, so please vote. Do you think it's rubella, measles, delayed drug hypersensitivity reaction, herpes simplex virus with urticarial rash, or Stevens-Johnson syndrome?
Okay, we'll give people another 5 seconds.
Okay, the most common is option C, good delayed drug hypersensitivity reaction. Yeah, so it's most likely a type 4 reaction to, she was on penicillin, she had a strep viridans infection, and that was the most likely cause for the rash. All right, and then this is a child we saw recently, a 6-year-old girl. She presented with lesions over her legs and lower abdomen. She also complained of a painful knee, which was swollen, and she also had lesions on her buttocks and in her panty line. She had normal INR, PTT, and platelets. So what do you think do you think she's got acute lymphoblastic leukemia? Does she have meningococcal sepsis? Is it an IgA vasculitis? Is it MIS-C or immune thrombocytopenia? Great. So you're all listening. It was an IgA vasculitis. Yeah. So the important things is she actually had normal platelets, and she didn't have much other systemic involvement. So she's not a Miss C. This is a 10-year-old boy. He was previously well. He presents with high fevers and a rash. The rash is not pruritic. He's got no meningism, but he does have abdominal pain and a severe headache. And the rash involves his palms. Interestingly, about 3 days later, he developed red cracked lips and a strawberry tongue. So what is the most likely diagnosis? He's got scarlet fever, Kawasaki disease, Miss C, enteroviral infection, or secondary syphilis. Okay, so scarlet fever is the most likely one. In fact, when we saw the child, we were worried about the rash on the palms, enteroviral infection, but the problem is the age. It's usually in much younger kids. He progressed, he had really high spiking temperatures and severe abdominal pain, vomiting, diarrhea, couldn't eat anything. And he was actually a child who had Miss C, and he responded well to treatment. He had a very raised CRP and ferritin and other laboratory, yeah. So in conclusion, most childhood episodes of fever and rash represent benign, self-limited illnesses with little or no sequelae, but you need to be able to recognize potentially significant illnesses such as meningococcemia, tick bite fever, acute traumatic fever, Kawasaki disease, and this Stevens-Johnson-Dress toxic shock syndrome, and staphylococcal scalded skin syndrome. And the red flags include toxic appearance, unstable vital signs, any meningismus or fever with petechiae or purpura. And those are my references. Thanks.